Dr. Saad,
Yes, sir.
are the students in?
Yes, sir. There are like 76 students in the class now.
Okay, so we are starting because we have limited time, so we cannot wait for more. Let's see what are the chats are.
Sure,
Okay,
we can.
guys, Assalamu alaikum, and thank you very much. Today we had some technical hitch from the server of Zoom, so this was not under our control. But I hope you people have done your job and you have already submitted the answers. The answer submission is important because we need to take the attendance and we'll submit these to Muntasir for attendance. And the second part is for the completeness of this activity. We have taken this. I have already shared this screen previously with you, and then you know that the purpose and all these things. Let's move on to the question number one. So I have question number one. I'll read the question and then Dr. Saad, could you please take anyone from MA1, any volunteer from group MA1 for
Mm.
answering these questions. Guys,
Okay, so
the second part, we just want to emphasize that since we have only 30 minutes, so whatever you submit your answers, you discuss your answers, don't worry. We will post the model answers onto the Moodle after finishing if we are not able to complete all the cases, we'll definitely put up the model answers for you. Thank you very much. So question number one, I'm reading the scenario, and in the meantime, may I request Dr. Saad to take somebody from MA1. A
yeah, so
solution of 5 millimoles per liter calcium chloride is separated from a solution of 1 micromole of per liter calcium chloride by a membrane that is selectively permeable to calcium but is impermeable to chloride. So question is, what are the magnitude and signs of potential difference that is generated across the membrane? May I request?
yes, so anyone from MA1, you can answer. You can unmute yourself.
Anyone?
Yeah.
Um,
Yes. What's your name?
my name.
This is MA1. This is male. So any female is.
Okay, so anyone from MA1, anyone would like to volunteer?
Guys, since we have limited time, so may I request you to please go ahead. If not MA1, who was talking, please take, go ahead.
Okay, I'm from everyone.
Sure, go ahead.
Okay, so the calculation basically goes 2.3 times 6. So our 2.3 RT over F has a constant value of 60.
Mhm.
Z is the charge of the ion, which in this case is calcium, so it's 2. So it's 30 log. Then concentration of solution. The way we did it was 0.001. You convert micromolar to millimolar, solution 1, over 5, which is solution 2. And that for us came out to be 111 positive, cell interior positive.
So, solution one is negative with respect to
Yeah,
solution two.
2.
Oh,
Yeah.
yes. So your answer is correct. So guys, everybody understand that how it is done? Who was explaining? May I know your name, please?
Aries.
Aris.
Yeah.
Is everybody very clear about Aris' answer?
Doctor, I have a question.
Yes, go ahead.
How do we decide which solution is C1 and which one is C2?
Very good. Aris, can you answer this question, please?
I mean, it's up to you really, but then you'll have to like change the concentrations accordingly with the fractions, and you'll get a different sign.
Yeah, but
Actually,
movement would be from higher concentration to lower concentration.
Yeah, true.
So
yes.
that's why you need to see where you would put 5 and where you put 1.
It is, yes, it is, always from diffuse from high concentration to low. So that's by convention, you have to take it like that.
Okay.
Okay, thank you.
Okay. We'll move to the next question. Aris, are you there?
Yeah, I'm there.
Yes. So can you just, I'll read a nerve fiber is placed in a bathing solution whose composition is similar to ECF. So, and they have given after the preparation equilibrates at 37 degrees centigrade, a microelectrode inserted into the nerve fiber records a potential difference across the nerve membrane as 70 millivolts, cell interior negative with respect to the bathing solution. The composition of intercellular fluid and extracellular fluid is shown as you can see the values. Intercellular sodium is 30 millimoles per liter, whereas extracellular is 140. Potassium is 100, where it is 4. Chloride is 5, where it is 100. So if the constant value is given, which ion is closest to the electrochemical equilibrium, what can be concluded about the relative conductance of the nerve membrane in sodium, potassium, and chloride under these conditions?
Okay,
Yes,
so
please. Yes, there is.
so basically the ion which is closest to its equilibrium potential at the current membrane potential has the highest conductance. So what you do is you do the Nernst equation again for each of these ions.
Exactly. For sodium, potassium, and chloride, you have to calculate the nerve's equilibrium potential of.
So
Yes,
for us, the sodium equilibrium potential came out to be 40 plus 40, cell
Okay.
interior positive.
Okay.
The potassium equilibrium potential came out to be negative 84, so cell interior negative.
Yes.
And equilibrium potential of chloride came out to be minus 78.
Yes.
Is cell interior negative. So minus 78, which is of chloride, is closest to minus 70.
Yes.
So equilibrium potential of chloride is the closest. Therefore, chloride conductance is the highest. Potassium is the second closest, so potassium conductance is the second highest. And sodium has the lowest conductance because it's the furthest away from equilibrium potential.
So this is very clear that you have to calculate the equilibrium potential, and based on to those equilibrium potential, you have to see that which one is closer to the membrane potential. Thank you very much, Ari. You have answered the questions very clearly. Is there any question from anyone? So you can write in the chat, please. Okay, guys, we are moving to the next question. So we have MA3. I'll read the, you all have read the scenario, so I'm not reading. I don't want to spend the time, but let's look at question number 3. MA3, please. Anybody from MA3?
Yes, doctor.
Yes. What's your name?
Salam Shabalot.
Okay, please read the question. Question number 3, please.
Okay, give the normal potassium distribution between intracellular fluid and extracellular fluid. Where is the most of the potassium located?
Where it is?
It's intracellularly, because intracellular potassium is 140, while extracellular is about 5.
Okay, so it is very simple question. Yes, MA4 lists the major factors that can alter the distribution of potassium between intracellular fluid and extracellular fluid. MA4, please unmute. Dr. Saad, could you please unmute anybody from MA4?
Yes, sure, doctor. So any student from MA4, you can unmute yourself. Any volunteers? Anyone from MA4?
Or anybody from the class?
Can I answer?
Yes, please. What's
Sure,
your name?
go ahead.
Shifa.
Okay,
I'm
Shifa,
not
please.
sure, but the factors that will alter is the ion concentration overall, intracellularly and extracellularly. Also, we can say that a receptor for the ion channel sensitivity, like if it's sensitive to allow a sodium entry or outside movement of potassium.
Okay.
And these are the two ones that I know, yani.
Yeah, I think Shifa, you need to look at certain hormones also. Like insulin is very important for moving the potassium inside the cells. The other important thing is the acid
and base.
Yes.
And aldosterone
metabolic
too.
acidosis can cause loss of potassium from the cell, and metabolic alkalosis will have an opposite effect. So you need to look at these two important things. One is the acid-base balance. So metabolic acidosis can cause loss of potassium from the cells, and acidosis, and alkalosis can cause the opposite effect. And insulin is very important in driving potassium inside the cell. So those are important things to consider.
تمام.
Okay, let's move to the next question.
Question number 5. Is there any volunteer from FA1, please?
Yeah, I
Anybody?
can answer the question.
Yes, please. Can you read the question for us?
Yeah. So describe the relationship between the serum potassium concentration and the resting membrane potential of excitable cells, example, nerve, skeletal muscle.
Yes.
Okay,
what is your
so we
answer?
know, oh, sorry. So we know that based off of the serum potassium concentration, it can affect the extracellular fluid concentration, and based off of the extracellular fluid concentration and related in relation to the intracellular concentration, that is what's going to determine the electrochemical gradient, which can determine whether potassium is going to flow inside to outside, which is usually how it is. But it can also determine like how strong that gradient is or how strong that current is. And we know that under like normal physiological conditions, that the resting membrane potential is closest to potassium's equilibrium potential. And so there is like there's the highest like, I guess, potential for potassium to go outside of the cell, but it only does so when the channels are open.
Yes.
Yeah, so that means that the permeability of plasma membrane to potassium will determine the potential at rest,
Yeah.
because it has the highest equilibrium potential. So it is the ability of the plasma membrane, how much it is permeable to potassium to move out, that would determine the potential at rest.
Yeah.
Make sense?
That makes sense.
Yeah.
Yeah.
Question number 6. So anyone from FA2, please?
I can do it. So how does
What
it
is it? Yes, go ahead.
how does a decrease in serum potassium concentration alter the resting membrane potential of the skeletal muscle? So
Yes.
since we have less potassium extracellularly, so the concentration gradient is going to be from like more potassium is going to leave from inside and go outside, and by doing so, it's going to leave the membrane potential in a hyperpolarized state. So then it would require a higher stimulus for the membrane potential to go back to the threshold, and then for the action potential to happen.
You said it needs higher potential.
It needs a higher stimulus.
No, I mean, if the potential is, if we can say, in the setting of hyperkalemia, the resting potential is shifted to a less negative value, that is from -90 to -80. So what happens to the resting it becomes closer to the threshold. So it is now easy to excitable.
It's more excitable.
Yes, it becomes more excitable. You are saying the opposite.
So she is talking about a decreased serum potassium. She is not talking about increased serum potassium. She is talking about hypokalemia rather than hyperkalemia.
Yeah.
That's the question, isn't it? A decrease in serum potassium, right?
Yeah. You're right in terms of hypokalemia. What Dr. Ahad is explaining is about hyperkalemia.
So this is, I mean, in both the conditions, the role of potassium is very clear to everyone. Is that okay?
Yeah.
Okay, let's move to the next. Yes. So we have question number 7. Can any volunteer from FA3, please?
Hi, doctor.
Yes,
I'm
go
from
ahead.
FA3.
What's your name?
Iman.
Iman, could you please read question number 7?
It says suggest a mechanism whereby a decrease in the serum potassium concentration could lead to a skeletal muscle weakness.
Yes.
So basically, like you just mentioned, the lower blood potassium basically makes it easier for the neuron to reach the threshold. So the threshold is lowered. This makes it more excitable. So basically, it starts off with increased depolarization. So first, there's a prolonged depolarization. But because of this prolonged depolarization, the cell slowly goes into a longer refractory period, and then it can't be excited anymore. So it starts off as weakness, but then slowly and slowly it leads to twitching and then paralysis eventually.
Okay. Is that clear to everyone?
Yes, doctor.
Question number 8. Can we have FA4, please?
Yes, doctor, that's me.
Okay.
Okay, so normally
Can you
during
read the question, please?
why did Ahmed's weakness occur after exercise? Why did eating a banana worsen his weakness?
Mhm.
Okay, so exercising causes the potassium to shift from intracellular to extracellular fluid, right? So usually after the exercise is done, the potassium plus is reaccumulates in inside the skeletal muscle, but because of the disorder does not, so it exaggerated his hyper. Okay, sorry, doctor, I'm nervous. Shreya.
But Amal, you know that banana is rich in potassium. So why there would be problem in this case when she eats banana? There is more, the hypokalemia becomes worse.
And it weakens.
Because it's wait again. What's your question, doctor?
So my question is, banana is quite rich in potassium. So why eating banana would cause worsening of the,
Because the insulin dependent potassium uptake augmented the post exercise uptake.
Okay.
Causing the further hypokalemia.
Yep.
Yes.
So because banana is also rich in sugar.
Yeah, it has it basically insulin would have a role in this.
Yes. So very good. Question number 9, please.
Okay, thank you.
Who is going to FA5, please?
Assalamu alaikum, doctor.
Walaikum salam. What's your name?
Rima Silmi.
Rima, please read.
Okay, so how would potassium supplementation be expected to improve Ahmed's condition?
Yes. Hello.
I think her mic muted. You can unmute yourself again. Or if anyone else would like to answer.
Yes, doctor. So upon discussion with my group, we decided that the high levels of potassium normally cause abnormal heart and skeletal muscle functions. They lower the cell resting or the resting membrane potential for the cell, and it makes the cell more hyperpolarized, which makes it harder for the cell to reach the threshold to continue with the propagation of the action potential.
So how does this, in this case, potassium supplementation will improve this person's condition?
So upon improving potassium, we would make the cell less hyperpolarized. So it would be easier to reach the threshold to propagate the action potential.
Okay. So this case is about, primary hypokalemic periodic paralysis. So this is a condition which is called primary hypokalemic periodic paralysis, where you have problems with the ion channels. And when you are going to supplement, there are mutations in ion channels, especially sodium and calcium channels. And that's why the resting membrane potential is disturbed. So when you are going to supplement, in this case by potassium, it will restore the resting membrane potential. And that's why in this case, giving potassium will improve this condition, because there is a congenital problem with the sodium and calcium channels there, which results in this condition, and you have the intracellular potassium, there, which the potassium cannot go out, and and there is no exchange of sodium and calcium, which results in the problem in this case. So once you start to supplement potassium, it will bring the resting membrane potential back to normal. And that's why potassium supplementation helps in this condition. But using banana does not help because it also stimulates insulin secretion, which moves the potassium further inside the cell. And you cannot maintain the resting membrane potential. Okay?
Okay,
Doctor?
thank you, doctor.
Yes. Right.
Okay, let's move to the next.
Do you have any questions, anybody?
I have one more question.
Yes, go ahead.
I read in one sources that eating banana causing hyperkalemia.
Yeah, so eating banana would result in hypokalemia because potassium will move inside the cell because of the insulin.
So if it's move inside the cell, it will induce hypokalemia, right?
Sorry?
If it's move inside the cell,
Will be hypokalemia. You're right. You're right.
So you will not have hyperkalemia.
You would have hypokalemia.
Okay.
Hypo,
Thank you so much, doctor.
not hyper. Hypo.
Because of insulin, the what you are doing, causing more and more. You are stimulating insulin, and it is the effect of insulin which is causing hypokalemia. Okay, let's move to the next question. Scenario, please. Scenario 3, we have.
Doctor, can I ask a quick question?
Yes, go ahead.
Okay, does hypo or hyperkalemia cause muscle weakness?
Yeah, so what is happening, the muscle weakness is happening because there is no ion exchange, these ion channels, both sodium and calcium ion channels are affected, and there is mutation there. And that results in, once you have problems with these ion channels, potassium cannot move out of the cell. Do you understand what I'm saying? So muscle weakness is not because of potassium, it is because of the transport proteins for sodium and calcium channels, which are mutated in this condition.
I understand, doctor. The two channels that are mutated, I believe one of them is called SCA4. But my question is, in general, if the patient was healthy and normal, would hypo or hyperkalemia cause muscle weakness?
Yeah, so the action potential would be disrupted by hypo and hyperkalemia, in both conditions, because the resting membrane potential is going to change.
Okay, thank you, doctor.
So we have MA1 again. This is.
Assalamu alaikum, doctor.
Walaikum salam. Who is this?
Abdulaziz, doctor.
Okay, Abdulaziz, please.
Okay, bismillah.
What is this condition? What is this condition? Though you have gone through the case, what is this condition?
I don't think this is a condition, doctor.
So, you have gone through the whole case. So what we are doing, this is.
I think this is just mechanism action of anesthesia.
Yes, Abdulaziz. So please, can you read the question number 10, please?
Okay, so it's described the phases in the ions responsible for the normal nerve action potential.
Yes.
So I want to just initially say that there's obviously the resting membrane potential, and this is maintained by the sodium-potassium pump and the potassium leak channels. That's the maintenance of the resting membrane potential. So initially, for a normal nerve action potential, we have the depolarization from the ligand-gated sodium channels, and this causes a graded potential. And once the graded potential is generated, if the super threshold at the level of the axon hillock is reached, then there's a propagation of an action potential. And for the initial phase of an action potential, there is basically an upstroke due to the opening of the voltage-gated sodium channels. At around 35 millivolts, there's inactivation of these gates, and then the voltage gated potassium channels are going to start opening, and this leads to repolarization. And this is also the absolute refractory period when there's no possibility of an action potential being generated. So once these voltage gated potassium channels are then slow to close, which allows the overshoot below the resting membrane potential or the hyperpolarization. And this is just the refractory period. And then the sodium potassium pump reestablishes and then reestablishes the resting membrane potential.
Okay. Abdulaziz, you said, I just want to ask you, you said that it is only the supra threshold which causes, the action potential. Does threshold causes action potential?
No. If it has reached, basically, it also depends on the length constant. So if the gradient potential has the length constant is basically when the potential reaches around 37% of its original point. So if this has reached above the
even
threshold,
the stimulus, that's what I just want to add. Even the stimulus is threshold. If it is able to open that adequate number of voltage gated sodium channels, then there will be action potential.
Yes.
Yes. So even the threshold or supra threshold, but if it is sub threshold, it will result into local potential or graded potential. Yes. Question number 11. MA2.
Yes, doctor.
Yes. What's your name?
Hamza.
Hamza, please.
So I read the question, yeah?
Yes.
Okay. Lidocaine and other local anesthetic agents block action potentials in nerve fibers by binding to specific ion channels. At low concentration, these drugs decrease the rate of raise of the upstroke of the action potential. At higher concentrations, they prevent the occurrence of the action potential altogether. Based on this information and your knowledge of the ionic basis of action potential, which ion channel would you conclude is blocked by lidocaine?
Yeah.
So lidocaine is lipophilic. It will get into the cell and it will bind to the voltage-gated sodium channels, the internal portion of the voltage-gated sodium channels, and inactivate them. So they will close the voltage-gated sodium channels and they will prevent the upstroke of the action potential.
Okay. Is there any question related to that? Everybody is very clear about that? Okay, let's move. Thank you. Let's move to the question number 12. MA3, please. Any volunteer from MA3?
Yes, doctor.
Yes. What's your name?
Salam Shabalul.
Okay.
Lidocaine blocks ion channels by binding to the receptors from the intercellular side of the channel. Therefore, to act, lidocaine must cross the nerve cell membrane. Using this information, if the pH of the epidural space were to decrease from 7.4 to 7.0, which is becoming more acidic, would drug activity increase, decrease, or be unchanged? And please explain your answer.
Yeah.
The group, we decided that it would decrease because it's a weak base and it's creating more acidic environment will make it more charged, thus decreasing its absorption. And also when we looked up the optimal pH for lidocaine, it was between 3.5 to 7. So.
And in this case, it was?
Doctor, I have another idea. I have another answer.
Okay.
And like if we allow inside the axon to be more acidic and we have a basic drug, so when the weak base is entering, correct me if I'm wrong, is entering inside the axon, it will let it ionize and stuck inside the cell. So I think the activity will increase of the drug.
So in other words, the lower the pH, the lower proportion of the non-ionized form, which can penetrate the cell. And if you have higher the proportion of ionized form, which cannot penetrate the cell. So thus the low pH would decrease the amount of lidocaine which can enter the cell because they would have lower proportion of non-ionized form which can penetrate the cell.
So we will have increase or decrease?
You would, in the low pH, you would have decreased amount of lidocaine because the proportion of non-ionized form which can penetrate the cell would be lower.
Tamam.
Okay.
Thank you, doctor.
Question number 13. Anyone from MA4, please?
Hello, doctor. Assalamu alaikum, doctor.
Walaikum salam. What's your name?
Gibran.
Gibran, please. Question number
So the question is, based on your knowledge of how action potential and how nerve action potentials are propagated, how would you expect lidocaine to enter the conduction of the action potential along the nerve fiber? So now the way an action potential is normally conducted is that there is a change in potential at a node of Ranvier, which then leads to the opening of fast voltage gated sodium ion channels at the next node. And then there is a change in potential at that next node, which causes the voltage gated sodium ion channels of the node after that to open. And so this is how the action potential is normally propagated. Now the lidocaine, as the question said, it blocks the sodium ion channels. So obviously there won't be any propagation because it's not opening.
Okay, very good. Let's move to the next scenario. Thank you very much. Question scenario number 4 and question number 14. FA1, please.
Yeah, I can answer it.
Okay, please.
Okay, so it says discuss the production. Oh, should I read the whole scenario or just
No,
question
I
14?
mean just question, please.
Okay, thank you. So discuss the production, circulation, and absorption of cerebrospinal fluid, CSF. So if we're talking about production, then the main site of production is in the lateral ventricles, because the lateral ventricles has like these modified ependymal cells called the choroid plexus. And what the choroid plexus is going to do is that it's going to start to...
it's not only lateral ventricles, all the ventricles would have choroid plexus. So it would be produced in lateral, third, as well as in the fourth ventricle. Okay.
Oh, okay. But is it more in the lateral ventricle or is it equal
it is
throughout?
more in the lateral ventricle because it's bigger, but there is choroid plexus in both in lateral ventricle, in the third ventricle, as well as in the fourth ventricle. So it is produced in ventricles. That would be a safe statement.
Okay, that makes sense. But what the choroid plexus is going to do is that it's going to pump sodium ions into the lumen of the ventricle. And because sodium is positively charged, it's going to attract the chloride ions as well. And then because we have these two ions, sodium and chloride, it's going to cause like osmotic pressure, which is going to attract water as well. And so I think that's why the chloride concentration in cerebrospinal fluid is slightly higher than plasma. And I think at the same time, potassium is being pumped out and is not like, it's limited in terms of the cerebrospinal fluid, and that's why it's slightly lower compared to the plasma levels. And I think glucose is as well. But regardless, that's how we have the formation of the cerebrospinal fluid. And then if we start with the lateral ventricles, the cerebrospinal fluid is going to move from the lateral ventricles into the third ventricle through the foramen of Monro. And then from the third ventricle into the fourth ventricle using the central aqueduct of Sylvius. And then from the fourth ventricle, there's kind of three ways that it can go. It can go either through the like laterally or medially. If it's lateral, then it's foramen of Lashka, and if it's medially, then it's foramen of Majindi. And then,
Majindi.
sorry?
Oh, yes.
Majindi?
Yes.
Oh, okay, sorry. And both of those are going to lead up into the subarachnoid space, which is surrounding the brain. And then it can also go down, the cerebrospinal fluid can also go down into the central canal. But if it goes up into the subarachnoid space, it can eventually enter into these structures called arachnoid granulations. And the arachnoid granulations are where the cerebrospinal fluid will drain into the venous sinuses, which is the reabsorption of the cerebrospinal fluid.
Good, very good.
Can we have question FA2, please?
Okay, why this patient has...
What is your name?
My name is Saraswati.
Okay.
So why this patient has a head circumference above 97th percentile. So from with the physical examination, she had a full anterior fontanelle and also the lateral ventricles were dilated. So we decided that she has hydrocephalus And the reason being is that maybe the cerebral aqueduct is blocked, so that might be the reason why. She has a head circumference above the normal.
Yep. That's
Very
a
good.
good answer.
Question number 16, may I request FA3, anybody from FA3, please?
Yes.
What's your name?
Noor.
Noor, go ahead, please.
Okay, so we've decided that the site of congenital abnormality would probably be a aqueductal stenosis, because if the aqueduct of Sylvius is narrowed down, then the cerebrospinal fluid would accumulate in the upper ventricles and mostly in the lateral ventricles, which is why it was dilated, causing hydrocephalus.
Is there any genes involved here?
If it's a mutation,
Yeah.
then yes.
Yeah. So what, do you know the name of the gene? No problem, but yes, go ahead.
Something.
L1CM.
Yeah.
Okay. We will move to the next scenario. Question number, scenario 5. Question number 17. FA4, please. Please introduce yourself.
Yeah, doctor.
Yes, what's your name?
Hiba.
Hiba, please go ahead.
Okay, so the question says describe the pyramidal pathway. So first, the pyramidal pathway is the primary pathway. It's responsible for scale movement modulated by two structures, the basal ganglia and the cerebellum. And it consists of two separated pathways, the corticospinal pathway and the corticobulbar pathway. The corticospinal pathway, neurons coming from the cortex into the anterior gray horn cells of the spinal cord. Its principal function to supply the distal musculature in the limbs and the trunk. The corticobulbar pathway, neurons coming from the cortex into the cranial nerve nuclei in the brainstem, which is called the bulbar, or the corticonuclear, means from the cortex to the cranial nerve nuclei, as I say. They supply the head and neck muscles by the cranial nerves. Okay, so first, if for example, at rest, the movement status, the cerebellum will be the controller, and it will be responsible for the correction of the motor movement. While if the body is at rest, the basal ganglia will be the controller. So the basal ganglia will send continuous inhibitory signals to the motor cortex to have no movement at rest, as I said. And when the cortex decides that
Hiba, stick to the course of the pyramidal pathway. So just explain to us the corticospinal pathway. Starting from the cortex all the way to the spinal cord. What is the how this pathway goes from where to where? So just stick to the question, which is describe the pathway, the pyramidal pathway.
Okay, so after the corticospinal tracts originate from the cortex, they will merge together and descend through the internal capsule. Then
after passing through the internal capsule, they would pass from where?
Yeah, so they pass the internal capsule. They will pass through the front part of the midbrain. They will form the cerebral peduncles there in the midbrain. Then the cerebral peduncles going to pass through the midbrain, then will reach the pons in the ventral portion. They will make the pontine nuclei.
No.
Then they will be
the pontine nuclei, they would get disrupted.
Yes.
They would not remain as a bundle of fibers.
Yes.
in the ventral part of the pons. So when they reach the medulla, they will join together to form the pyramids. That's why they are called the pyramidal pathway. Yeah, go ahead, Hiba.
Okay, so they will be scattered. 85% of them will cross the midline, forming a motor decussation and descend to the lateral white column in the spinal cord. They will form the.
So this decussation would happen at the junction of medulla with the spinal cord. So the lower part of the medulla, the 85% of the fibers of the corticospinal tract would decussate, and they would move towards the lateral side of the opposite white column. So they form a motor decussation at the lower part of the medulla. Yes, go ahead.
Okay, the other 15% of the fibers will remain in the ipsilateral side, and they will descend in the anterior white column, and they will form the anterior corticospinal tract.
Okay.
They will also cross the midline at the spinal cord level and synapse with the lower motor neuron at their particular segment of the spinal cord.
Okay, thank you, Hiba. Thank you. We will stop here, and the other questions which you see in this, you would get the answers. You can compare your answers with the standard answers which are given in the the answer sheets which we are going to upload on the Moodle. So if you have any questions, you can ask questions later on. Thank you very much.
Thank you very much. Right now, I'll upload the answers onto the Moodle, and please compare your answers. And then, if you have if you have any questions, you can refer to the people who have taught you. Thank you very much.
Right. Thank you, sir.
Okay. Dr. Ahmed, thank you.
Thank you.